Hello, everyone. And today we're going to talk about neurocognitive disorders related to the psychiatric mental health nurse practitioner exam. So the first one we're going to talk about is delirium. So delirium is a syndrome and not a disease with an acute onset that causes short-term changes in cognition. Delirium is a short-lasting, reversible neuropsychiatric condition that is characterized by disturbances in psychomotor behavior and disturbances in consciousness, perception, thinking, emotions, and cognitive function due to one of these reasons. So either there is an underlying medical condition, it's substance-induced, multiple physical problems, or due to medication, sleep deprivation, or other cause. When we look at delirium, we're going to see a waxing and waning of attention. It is a brain disturbance characterized by the DSM as requiring a disturbance of consciousness or attention, a change in cognition that develops acutely and tends to fluctuate. These patients have lucid periods followed by periods where they become very disoriented. Delirium is a common medical issue with a high rate in the ICU in the hospital, and assessment tools can be patients with delirium have trouble with things like serial threes, so counting down from 21 by 3, drawing a clock, or spelling the word world backwards. There are 4 subtypes of delirium. So there is hyperactive, which is characterized by motor agitation, restlessness, and aggressiveness. These are the patients that are pulling out their IVs, yelling, throwing things, and seeing visual hallucinations. Then there's hypoactive, so characterized by motor retardation, apathy, slowed speech, and the patients appear sedated. There can also be a mixed type where you see both of these kind of symptoms and without motor symptoms. So patients only experience the cognitive symptoms of delirium. And delirium represents a critical breakdown in brain function due to severe metabolic disturbance of some kind. Exposure to anesthesia is common cause of delirium in hospitals, and it is estimated that post-operatively 40% of people experience delirium. However, most cases are transient and short-lived. So the incidence and demographics, so it's common among older adults and is often overlooked and mistaken for other conditions, which one can be like psychiatric conditions, right? We talked about in our catatonia discussion, catatonia and delirium having similar kind of presentations, also delirium and dementia. Sometimes people can get confused, which we'll talk about more later in this talk. In people with psychiatric disorders, it's often mistaken for worsening of psychotic symptoms instead of delirium itself. Also, the treatment for psychotic symptoms makes delirium worse, so that's also not helpful. Prevalence varies based on age, client setting, and sample. It's the highest in hospitalized older adults. So 0.4% of the US population 18 and older, 1 to 2% of those 65 and older, 6 to 56% of hospitalized clients, 15 to 53 in post-ops, 70 to 87 in older adults in the ICU, 60 in nursing home patients, 25 in clients with cancer, and 80% in terminal clients nearing death. It does have a poor prognosis, so a 1-year mortality rate of clients with delirium is up to 40%. So risk factors: advanced age, multi-system medical conditions, substance use, visual and hearing impairment, and past episodes of delirium or pre-existing brain disorder or cognitive impairment. Assessments and screenings. So disturbance of consciousness develops over a short time, usually within hours to days. That is a key characteristic of delirium that is different than dementia. Dementia, and we're going to talk about this more, will be a slow progression over time. Delirium is going to happen fairly quick. These disturbances tend to fluctuate during the day. Sleep rest cycle disturbances, so clients are awake at night but sleep during the day. Impaired recent and immediate memory, psychomotor agitation. Course of illness may resolve within hours to days. If the underlying physiological disturbance is recognized and treated, symptoms when unrecognized can last for months, and most symptoms resolve within 3 to 6 months. And in the ICU or in medical settings, they typically use the Confusion Assessment Methods Instrument. Also, the CAMS assessment is the other name. So physical exam findings. Usually there's non-specific neurological abnormalities, so tremors, incoordination, urinary incontinence, myoclonus, nystagmus, asterix, so flapping motion of the wrists, increased muscle tone, and reflexes. For a mental status exam, they generally have an unkempt appearance, disheveled and highly inattentive, impaired, disorganized, rambling, incoherent, and slurred speech. Their affect, usually rapid, unpredictable shifts of affective state. They can be lethargic or agitated. The client typically can't express their mood. Their thought process is disorganized, distracted. They can have perceptual disturbances, can have hallucinations, disorganized and distorted thought content such as delusions and hallucinations, disoriented to time and place, memory impairment, concentration, abstract, and judgment, grossly impaired. For diagnostic and laboratory findings, there should be some finding consistent with an underlying physiological etiology. Workup includes standard tests. So you're going to do your blood chemistry, CBC, thyroid function, syphilis, HIV, urinalysis, chest radiography, serum and urine screen. We can see electroencephalopathy abnormalities, so generalized slowing or generalized increased activity if delirium is related to alcohol withdrawal. Our clinical management is to undertake treatment of the underlying condition. That's what needs to be treated, is what is causing the delirium. That's what we have to treat. And we want to avoid the use of new medications whenever possible because they could cloud the diagnostic picture. Pharmacological management should be treatment focused. And if the patient is having psychotic symptoms or agitation, we can give them antipsychotic medications. We can also give them anxiolytic medications if needed as well. Non-pharmacological management, so we need to monitor for safety needs. If they're pulling out IVs, maybe they need some hand mitts. If they're elderly, determine reality orientation frequently, pay attention to basic needs like hydration and nutrition. They should be neither sensory deprived nor sensory overstimulated. It's helpful to have them in a room with familiar people or pictures, a clock, calendar, and regularly oriented to person, place, and time. So delirium health considerations, so there's high morbidity and mortality rate. High morbidity results from injury or associated problems like pneumonia, hydration, and nutritional deficits. Safety concerns exist with delirium. Remember this with delirium. So drugs, electrolyte imbalances, low oxygen saturation, infection, reduced sensory input, intracranial issues, urinary and renal retention, and myocardial. Lifespan considerations. So children are susceptible related to immature brain development, often mistaken for uncooperative behavior. If a child is not soothed by common methods, delirium is suspected, most common in febrile states, and medications are known to affect cognition, especially those with anticholinergic medications. And older adults have a susceptibility related to physiological changes of aging and happens more often in men. All right, so that was delirium. Now we're going to talk about dementia. So dementia is a group of disorders characterized by a gradual development of multiple cognitive deficits, impaired executive functioning, impaired global intellect with preservation of level of consciousness, impaired problem solving, and impaired organizational skills, altered memory, multifactorial etiological profile, primary causes mostly unknown, general medical conditions. It can be a result of a substance use, reaction to medications or other ingested agents, or a combination of all of these factors. And there is a hereditary component that can be related to late onset dementia. So dementia is a term used to describe the loss of cognitive functioning, a disease of the brain. We can see here a picture of a normal brain versus a brain with dementia. There are several different types of dementia. So Alzheimer's is the most common. There's vascular, Lewy body dementia, and frontotemporal dementia, and mixed. And we're going to talk about these differences. So with dementia, there's also different types. So there is a cortical and a subcortical. So for cortical, it results from a disorder that affects the cerebral cortex of the brain, playing a critical role in the cognitive process such as memory and language. So these types are Alzheimer's, Creutzfeldt-Jakob disease are two types. Characteristics include severe memory impairment, aphasia, meaning the inability to recall words or understand common language. With subcortical dementia, this results from a dysfunction in the part of the brain that are below the cortex. Examples are dementias of Huntington's disease, Parkinson's disease, and AIDS dementia complex. Characteristics include changes in personality and attention span with slowing down of thinking. Early symptoms include depression, clumsiness, irritability, and apathy, but the end stages result in the same breakdown of brain function as corticodementias. So you do want to remember the two differences between these for the exam. So when someone has cortical dementia, it affects their language and memory. If they're having aphasia, it's important to remember that it's cortical dementia. Where subcortical dementia, you're going to see the depression, the irritability, the apathy, and the motor symptoms. So again, here is another chart that shows the difference between cortical dementia and subcortical dementia. So again, with the cortical dementia, you're seeing an example, Alzheimer's disease, seeing deficits of speech being like a key thing, poor recognition of learning. Typically, you're not seeing the depressive symptoms and you're not seeing the motor symptoms, but you are seeing the language symptoms. And then with the subcortical, you're seeing, the depression, the apathy, the dystonias, and the motor symptoms, and the cognition symptoms is slowed as well. So yes, those are the differences. All right, so incidence, demographics, and risk factors. So it's often misdiagnosed or unrecognized, especially in the early stages of young clients. It happens between 1.6% for people in the US ages 65 and older, and 16 to 25% in people 85 and older. Alzheimer's is the most common, affecting about 4 million people in the US a year, and the duration of illness is usually 8 to 10 years. Risk factors are age, multi-system medical illnesses, genes, and a history of substance use disorder. So for Alzheimer's disease, this is the most common, and it is a gradual onset and progressive decline without focal neurological deficits. The hallmark is amyloid deposits and neurofibrillary tangles. You're going to see diffuse cerebral atrophy and enlarged ventricles with decreased acetylcholine and norepinephrine. There are various genes that are related to Alzheimer's, which are listed there if you are interested. All right, so vascular dementia. This is the second most common. It was formerly called multi-infarct dementia. It's primarily caused by a cardiovascular disease and characterized by step-type declines. Most common in men with high blood pressure and cerebrovascular risk factors. Hallmarks are carotid bruits, fundoscopic abnormalities, and enlarged cardiac chambers. I like to remember this because it's literally called vascular dementia. So it's the vascular system related to cardiovascular disease. And because of that, you see like a step type decline. So dementia can also be due to HIV disease. So this is a subcortical dementia. We're going to see parachimal abnormalities visualized on an MRI scan, HIV-associated neurocognitive disorder of HIV encephalopathy are less severe forms. HIV can cause many psychiatric symptoms. It's manifest by progressive cognitive decline, motor and behavioral abnormalities, and it co-occurs with OCD, PTSD, generalized anxiety disorder, depression, and mania. The development of dementia with HIV is an indicator of poor prognosis, and death usually occurs within 6 months. In later stages of infection, psychotic symptoms can occur. And clinical signs of late-stage HIV dementia is cognitive impairment, mutism, seizures, hallucinations, delusions, apathy, and mania. And HIV medications can interfere with psychiatric medications, so we have to prescribe with caution. Then there's something called Pick's disease. This used to be called frontotemporal dementia, and it is a neuronal loss, gliosis, and Pick's bodies are present. Most common in men, and we'll see a personality and behavioral changes in the early stage, cognitive changes in the later stage. We can also see a Kluver-Bursey syndrome, which is hypersexuality, hyperrolity, and placidity. Then there's something called Creutzfeldt-Jacobs disease. This is a fatal and rapid progressive disorder occurs mainly in adults in middle age or older. It initially manifests as fatigue, flu-like symptoms, and a cognitive impairment, but later manifests with aphasia, apraxia, emotional lability, depression, mania, psychosis, personality changes, and dementia, and death usually occurs within 6 months. Huntington's disease is a subcortical type of dementia. It's characterized mostly by motor abnormalities called choreathoid movements, psychomotor slowing and difficulty with complex tasks, memory, language, and insight usually intact until the later stages, and has a high incidence of depression and psychosis. So for the signs of Huntington's disease, you're going to see motor abnormalities called chorea, dystonias, myoclonus, Parkinsonian symptoms. For cognitive, you're going to see difficulties with executive functioning, memory loss, and subcortical dementia. And psychiatrically, you'll see a depressed mood, apathy, irritability, agitation, anxiety, obsessive compulsive behaviors, and psychosis. Then there's Lewy body disease. So this is caused by Lewy inclusion bodies in the cortex. It presents with recurrent visual hallucinations, Parkinson's features, and adversely reacts to antipsychotics. Some dementias can be stopped or even reversed. So for example, normal pressure hydrocephalus is excessive cerebral fluid in the brain, puts pressure on the brain, and requires an insertion of a shunt. Cerebral vasculitis responds to an aggressive treatment of immunosuppressive medications and treatable infections of the brain. So there is a progressive and gradual decline in brain function. You can see the picture of the brain up above, how it kind of like breaks down. You're going to see issues with a decline in memory, problem solving. They're going to be confused. They're going to have language and communication issues, poor judgment. They're going to be impulsive, have mood and personality changes, and have difficulties with gross and fine motor skills. So dementia. So the normal person lives well with change, has no significant brain changes in normal aging process. This is the way dementia sort of progresses. So with mild dementia, these people can have, normal daily habits and routines. Things are changing. They might be repeating themselves or asking the same questions or denying have told you something that they told you. They might report the person is more dependent, insecure, or worried. They don't really like things to be different and they can't relax. They feel rigid and inflexible. When you get to a mild moderate, there is a noticeable change. Time and distance have no meaning. They want to be on the go, but they get lost or they don't know where they're going. They have a hard time finding words or communicating the wrong words. They don't know there is a problem, so they accuse others when they make mistakes or misplace things. And caregivers need to be very go with the flow when somebody is at this stage. When you get to moderate, they're sort of caught in the moment. They're all about sensations, sensory needs, and sensory tolerance. They either like it or they don't. These people are going to hunt, gather, touch, feel, smell, and taste things. They may no longer connect the steps of completing a task, and personal care starts to be challenging. They may resist assistance. They have no safety awareness, and it's harder to process words and express needs. When you get to moderate or severe, these people are dependent on others. Their fine motor skills are a problem. Holding things, bringing a fork or cup to their mouth, they'll have difficulty chewing and they might be a choking risk. They like to walk but have poor balance and difficulty moving backwards, does better moving forward, so they're a fall risk. Their sleep-wake cycle is off. Transitions are difficult, going from one thing to the next. Resistance is verbal and physical. They may use language they have without any filter or word choices. They still connect with facial expressions and tone, and they retain rhythms. They can sing a familiar song without difficulty, or they can dance a little bit. When you get to severe dementia, they primarily live inside themselves. Their limbs are very stiff. People try to pull them will result in a fear response or screaming behaviors. They have moments of connections visually through touch and sound. They have problems swallowing, and then they have brain failure, and ultimately their body shuts down. Caregivers need to meet the person where they're at in this process and recognize how they can help them live at this time. So when it comes to our assessment, we have to do a cognitive and functional evaluation at least every 3 years for those 65 and older. baseline and regular cognitive evaluations to monitor cognitive decline and treatment responses to medications in those with dementia. We want to assess for history of present illness, the time frame, progression of associated symptoms, get a med history, get a psychiatric history, social history, medications, validate this with family and caregiver, and assess for any memory impairments, because those are usually the earliest symptoms. So instruments for assessing impairments, and we talked about this a few other places. So you have the mini mental status exam, which can be scored 0 to 30. The higher the score, the better cognitive function. So we'll go over this more when we go over assessments and scales. So don't worry too much about remembering the numbers, because we're going to go over tricks to do that. Then we have the Montreal Cognitive Assessment, also called the MoCA. This is a 10-minute test that assesses the cognitive domains like memory, language, and attention. The test is scored by assigning points to different sections. Total score is 0 to 30. And again, with any kind of cognitive scale, typically the higher the score, the better the cognitive ability. That is important to know. And you're going to go over in the section where we talk about scales and assessments and memorizing them. We'll go over the ones that you need to kind of have memorized for the exam and tricks for that. There's also the mini cog, again, very similar. This involves a clock drawing test, a recall score. They're all kind of very, very similar in assessing cognitive function. Then we have the St. Louis University Mental Status Exam, also called the SLUM. Again, very similar, and we'll go over the scoring for this in our talk about scales and assessments. So we're going to do a physical and mental status exam finding. So things we may find is unilateral transient vision loss, described as a curtain over the eyes. Might have unilateral focal motor weakness, asymmetrical reflexes, apraxia, decreased ADLs, mutism, echolalia, deterioration of language skills, affect. They might be labile. They might have a depressed mood. They might have agnosia. They might, it's probably hard to figure out what they're thinking because they're not really able to answer questions a lot of the times. They might be disoriented, have impaired memory, be distractible, concrete kind of thinking, and has grossly impaired judgment. Diagnostically, we want to do our basic kind of blood tests that we're doing for mostly everything. CBC, chem panel, thyroid function, B12 folate, syphilis, alcohol use in a drug screen, urinalysis, pulse ox, and neuropsychological testing may be helpful. So clinical management. So patients with dementia can have challenging behaviors. They might have behavioral disturbances, are most common for patients with dementia to be admitted to the hospital. As the nervous system degenerates, the person is less able to cope with stress. Staff must be able to recognize these behaviors and purpose and meaning. It may be a patient's way of trying to communicate something that they are unable to verbally express. We remember that we talked about this affects language skills a lot. Characteristics of quality caregivers. So we want to be well-informed, focused, and attention, have flexible, creative, and adaptive skills, and have the patience and understanding. So to be well-informed, we need to know about the patient, their life before the illness, their family members, the things they liked, the things they didn't like, because that's going to really help us to provide care for them. We want to think about what stage they are in when we talked about those like mild, moderate, severe. Understand safety risks, so the risk for falls, choking, and aggression. Implement a positive physical method. So for example, there's like a hand over hand holding that sometimes it can help to relax them. Know how and when to use diversion and distraction techniques and respond appropriately to wandering, agitation, aggression, paranoia, hallucinations, delusion, and sexualized behaviors. So therapy intervention. So we can use behavioral therapy to identify cause of problem behaviors and change the environment to reduce the behaviors. We can use recreational therapy such as art or pet therapy to reduce agitation and normalize behaviors. We can use reminiscent therapy or life review to process through any unresolved issues and recall the past. And we can maintain a simple daily routine for bathing, dressing, eating, toileting, and bedtime, and integrate their cultural beliefs into their treatment. Psychotherapy approaches for people with HIV-related dementia. So a lot of times the people can feel guilt and have like self-esteem negatively and have a fear of dying. They might not be able to give a complete and accurate history. Family or friends should be questioned about any unusual or mental status changes. The changes in level of activity and interest in other people or in personality are clues to an acute central nervous system disturbance. Some changes are directly due to brain dysfunction, while others are psychological distress of the systemic problem, such as like anxiety that the person is dying. The spectrum of neuropsychiatric and neurological manifestations depends on the severity of immunosuppression, and psychiatric disorders may pre-exist or result from the HIV, and even subtle neurocognitive impairment can affect psychological coping, and neuropsychiatric disorders are more prevalent in the later stages. So when we talk about positive physical methods, so our vocal tone and facial expression are important. We want to be friendly, caring, kind, and reassure. When we are talking to people or like helping them to walk, say like down the hall or something, being on their dominant side, people prefer getting information from their dominant side when they have like dementia. The hand over hand positioning is a sensory intervention. You can do like a pumping action where you kind of squeeze, and this can be useful when ambulating, dressing, and eating. And instructions are given one step at a time, and usually visual cues are demonstrated. Want to have focus and be attentive. Want to identify triggers that are contributing to the difficult behavior and try to keep in mind the situations that are causing the difficult behavior. To find why we're having these negative behaviors, we want to look at physical discomfort or pain. What is the caregiver activity that's going on? And then any emotional distress. So physical discomfort and or pain. So look for, are they sick or ill? Are they having a reaction to medication? Are they hungry or thirsty? Are they constipated? Do they have to use the toilet? Are they incontinent? Are they fatigued and tired? Are their clothes uncomfortable? Do they feel cold or hot? Are they overstimulated? And our caregiver approach, so the behavior of the patient with dementia can be challenging to a caregiver, but oftentimes these behaviors may be a result of what the caregiver is or is not doing. So it's important to remember the possibility when trying to meet their needs and understand the source of the behavior. So we want to look at attitude. So a patient will respond negatively to caregivers who are in a timeline to get the work done, or like any type of impatience. People with dementia can sense the caregiver's attitude, frustration, and will become anxious and angry in response. And then time is not experienced the same way for people with dementia. If they feel that the caregiver is rough, rushed, or pushing them to do things they're not ready to do, they may get aggressive or defiant. Invading a person's personal space can also make them uncomfortable. Asking them to do something that's overwhelming or difficult can also cause them distress. And giving too many instructions or directions can also lead to frustration. So emotional distress, these people can have fear, anger, sadness, lonely, frustration, and boredom. They can also have hallucinations and delusions. So hallucinations involve one of the five senses. We've talked about this. Delusions is a false belief they believe to their core. Hallucinations for people with dementia usually involve seeing things like children or people, sometimes, or like an animal also. They can occur anytime in the day, but often get worse in the evening and at night as the sensory environment changes. There's less stimuli and less light. And sometimes it's a misinterpretation of a real external stimuli, such as like an illusion. So the patient thinks someone is watching them in their room, but really it's just a shadow cast on the floor from a light outside. Environmental triggers can also activate these hallucinations or delusions. So if they hear something on TV, they might incorporate that story into their life. They can create a story that might have been generated by an emotion they experienced with the TV show, such as fear. It could even result in their targeting or accusing towards others. Caring for a patient with dementia and hallucinations and delusions. So verbal intervention in the damaged brain is not going to work. Patients with dementia respond better to visual cues. So meet the patient at the level of distress they're displaying related to the hallucination. Figure out how they feel about the image and what they're seeing. If it isn't scary, you can ask them to look more closely and carefully at it and ask them some details about what they are seeing. As their eyes work to process data, the other image shuts off because now their eyes are actively engaged in the task of processing visual data and they can't hold both images at once. So for example, if a patient says, "Do you see the cat over there?" you can say, "Can you tell me more about the color of the cat?" If it's a scary image, you want to alleviate the emotion. So get them to look at you, the caregiver, so they have an immediate sensory experience. To prevent them from being a target, move to their dominant side and use the hand under hand position while holding their hand. Gently provide some pumping action with your hand. This helps to activate their sensory system by causing pressure on the palm. Validate their concerns and assure the patient you're going to do something about it, then work to change the focus through a diversion. So tactile hallucinations, a patient may experience an actual sensory sensation that is being misunderstood. For example, the whiskers on a man's face might be thought of as worms growing out of their face. Hair moving on their arms might make them think that they're crawling on them. Picking behaviors may represent an experience of a tactile hallucination, but it might also be the result of boredom or their way of communicating discomfort. When caring for patients with tactile hallucinations that have dementia, we want to identify the source of the picking, talk to them and ask if they're able to verbalize what they're feeling. Try using pressure garments like IV sleeves. Provide them with something else to do with their hands, such as sorting pictures or playing cards. Try sensory diversion, such as weighted blankets, hand massages, scrubbing, or sanding activities to keep the hands busy. Rocking can provide vestibular stimulation, so another sensory diversion technique. So psychosis and agitation. So we want to try non-pharmacological therapies first and use antipsychotic agents for agitation or psychotic symptoms regularly if needed, right? So it's a risk-benefit analysis because we know that there is a risk with this patient population and antipsychotic medications. We use the lowest effective dose and attempt to wean periodically. Antipsychotics may cause many side effects or of significance in the older adults, such as EPS symptoms, sedation, hypotension, anticholinergic side effects. And benzodiazepines may be used for treating anxiety or infrequent agitation. When we have wandering behaviors, we want to look at is the patient experiencing increased stress or anxiety, restlessness, agitation, trying to find something that is recognizable? Are they hungry or thirsty, uncomfortable? Are they bored? Because of sensory deprivation, or do they have sensory overload? Patient sees people with their coats on and it triggers them to leave, like they want to leave. They think, oh, it's time to leave. People are putting their coats on. All of these things can lead to wandering behaviors. So validation therapy. So validating and respecting the patient's feelings in whatever time frame they may be living in, even if it isn't present day. So for example, an 82-year-old patient who is looking for their mother, even though their mother has been dead for years. To keep reminding the patient about the fact that their mother has long passed is only going to cause them grief and distress. Rather, validate the emotion and steer them to something else without them realizing. Do not attempt to relieve the distress by telling the patient that their mother will be here in a little while or some other untruth. The patient may not remember much, but they might cling on to that statement, which is then going to make things worse when the mother doesn't show up. Be flexible, creative, and adaptive. So around the middle stages of dementia, fine motor skills such as holding a toothbrush or fork become very difficult. They may need some assistance. We can also use like a hand-over-hand approach to give that care. Gross motor skills may still work, but movement may be restricted. They might get stuck or might only be able to move forward, not backwards. Staff may be able to use a rhythm to get the person to move or walk. Start by demonstrating to the patient how you shift your weight in a rocking motion. Start to march and then add a rhythm. So march 1, 2, 3, or the ants go marching one by one. Can kind of get them to start going. We want to be flexible, creative, and adaptive. The need for sensory stimulation may also be evident. The need to touch, feel, grab, and smell things. That staff can be creative in identifying and providing items that are safe, but meet their sensory needs. If the patient tends to put things in their mouth, the items you provide may not be something the patient could choke on. We have to be mindful of whatever we give them. We want to substitute, not subtract. So it's a form of redirection or diversion. So rather than trying to take something away from the patient, try to replace it with something else. So when a patient puts something in their mouth, it might indicate they're hungry or thirsty, but they're unable to communicate this. You could replace what you want to get from them with something else for them to eat. So if they have something that you don't want and they're trying to eat things, you could give them food to then try to take the other thing away. So as we know, these patients are fall risks because of psychotropic meds and agitation and anxiety and boredom and all of these things. We just want to be mindful, because if they fall, right, they have other diseases, muscle weakness, bone and joint issues. It's not good, especially when older people fall. To prevent falls, we want to offer instruction and assistance, establishing a toileting plan, prevent boredom. If they like to walk with them, respond to stress or de-stress, respond to signs of distress, never leave the patient alone with nothing to do, be attentive, and keep the environment organized and free of clutter. These patients may also have paranoia, so we need to be alert to nonverbal signs that might indicate the patient is experiencing paranoia. Are they eating and drinking okay? Are they spitting out their medications or refusing them? Are they suspicious? If they are paranoid, don't argue with them. Be patient, stay calm, discuss their concern. Also look around when the behavior occurs. What is in the environment? Is something triggering this? All right, so pharmacology considerations. So rule out or treat any conditions that may contribute to cognitive impairment and discontinue unnecessary medications such as sedatives and hypnotics. So the first kind of medication to treat dementia is cholinesterase inhibitors. This is because Alzheimer's happens when acetylcholine is too low. So cholinesterase enzyme breaks down acetylcholine, and these drugs inhibit the enzyme, therefore increasing acetylcholine. As the disease progresses, the drug benefit is lost as the brain stops producing acetylcholine. It can be initiated for mild to moderate Alzheimer's. It leads to modest clinical improvements, treats only the symptoms, slow loss of function, and may improve agitated behaviors. It does not prevent the pathological progression of the disease, not effective in severe and end stage. Should stop if side effects, usually nausea, vomiting, develop. Commonly used agents are listed up there in blue. So that is cholinesterase inhibitors. Then we have Namenda. This is not a cholinesterase inhibitor. This is an NMDA glutamate receptor antagonist. It does not act on acetylcholine. This works for moderate to severe Alzheimer's. It may slow the degenerative process. It promotes synaptic plasticity. Alzheimer's disease is to be caused by the overstimulation of glutamate, which is an excitatory amino acid, resulting in excitotoxic and neuronal degeneration. So this mechanism of action is to prevent that overexcitation of the glutamate receptor. It helps with memories. You can combine it with cholinesterase inhibitors. There is actually one called Namzaric, which is a combination med. Side effects are dizziness, confusion, vomiting, urinary incontinence, headache, rapid weight gain, changes in heart rate, and tingling of the hands and feet. So when we talked about delirium, we talked about dementia. This is like an overview chart of the comparison of both and how they are similar yet different. So for example, the big ones, so the onset, delirium has a very acute sudden onset, with dementia is a slow progression over time. The causes are different. Delirium is due to like an infection, an illness, withdrawal, or dehydration, where dementia is due to an underlying brain condition. Delirium is reversible. Dementia is not. Delirium is shorter time frame. Dementia is forever. So all of these things, right? This is we already went over it all. This is just all on one page for you to see. All right. So now we're going to talk about traumatic brain injury. So evidence of a traumatic brain injury, an impact in the head or other mechanism of rapid movement or displacement of the brain within the skull with one of the following: a loss of consciousness, post-traumatic amnesia, disorientation and confusion, and neurological signs. Brain injury results when the head is hit or violently shaken. A mild TBI, most clients achieve full recovery in 3 months. And if residual symptoms continue, 80 to 85% will clear in 6 months. And about 2% of the population and 30% of returning soldiers have this due to explosive devices. So prevention and screening for military personnel. So mandatory post-deployment screen for all veterans returning from combat. Traumatic brain injury screening, exposure to events that may have caused the brain injury, immediate symptoms, so loss of consciousness, dazed, headache, amnesia, onset of symptoms of problems that may indicate brain injury, and presence of symptoms in the past week. There are 4 factors that complicate recovery from combat-related concussions compared with mild TBIs acquired in civilian settings. So the physical and emotional trauma in the environment in which it occurs, the potentially repetitive nature of the concussion sustained over a tour, the high incidence of comorbid mental health conditions, and difficulty in following typical recommendations, such as rest. If they're in combat, they obviously can't. So symptoms of a TBI. So a mild TBI, you'll see mental status changes of poor concentration, memory deficits, difficulty, intellectual impairments, irritability, depression, anxiety. You'll see physical signs of dizziness, balance problems, headache, tinnitus, numbness, and tingling, vision changes, sensitivity to light, sensitivity to sound, extreme fatigue, and sleep problems. And they might be dazed and confused when it first happens. When you get to moderate and severe TBIs, you're going to have all those symptoms, but also with chronic and worsening headaches, nausea and vomiting, seizures, difficulty to arouse from sleep, slurred speech, unequal pupils, confusion, restlessness and agitation, weakness and numbness, and loss of coordination. People with traumatic brain injuries are also at risk of harming themselves. This is highest for males ages 18 to 19 with psychiatric disorders, aggressive behaviors, and substance use. Pharmacological management, there is no specific management for TBI. We treat related symptoms according to current evidence-based standards, and they do have increased sensitivity to side effects such as sedation, anticholinergic effects, seizures with tricyclics, bupropion, and amantadine, EPS symptoms, neuroleptic malignant syndrome, TD, neuroleptics with decreased neuronal recovery, and benzodiazepines, which will decrease memory, increase confusion, decrease coordination, have abuse potential. Cognitive disorder recommendations, so we can give methylphenidate to increase attention, processing speed, general cognitive function, learning, and memory, dextroamphetamine to increase attention and processing speed, bromocriptopine to increase executive functioning, and amantadine to increase general cognitive function, attention, and concentration. And when using medications, we start low and go slow. Non-pharmacological management, so treat comorbidities, safety plan related to self-harm, teach patients to identify signs of risk factors for self-harm, follow up with 1 year after anyone with TBI harms themselves, treat vestibular dysfunction with physical therapy to reduce dizziness, treat traumatic vision syndrome with occupational therapy, scanning and accommodation difficulties lead to headache, irritability, and fatigue, treat memory impairments with occupational therapy, teach about symptoms and implications for relationships and employment, avoid alcohol, and neuropsychological testing can be helpful. When it comes to psychotherapy, it can be supportive, CBT to increase understanding of relationship between cognition and emotion, target adjustment or development of new beliefs and assumptions. We can also use behavioral therapy. We can use family therapy, which is a behavioral, affective, and personality changes are most difficult for families to adjust to. Tips for families to concentrate on the issue and ask the TBI survivor for one thing at a time. If a memory is an issue, keep notepads near the phone and messages in place throughout the home. If anger and irritability is an issue, leave the situation if possible and wait for them to calm down. Cognitive impairment. So these are just tools in CBT that can help with some of the things related to TBI. So for impulsivity, there is a stop, think, reflect feature. Decreased awareness, encoding, and recall. There's monitoring problems and successes. Memory, we can use audio tapes of sessions. And executive impairment, we can develop independence and problem solving for everyday difficulties. Therapy by the psychiatric mental health nurse practitioner for people with TBI, so we can focus on real life difficulties in the here and now, monitor speech and complexity of comments, adjust session length according to their attention and fatigue, reestablish an acceptable sense of self, and instill hope without making predictions of a successful rehabilitation outcome. All right, and that is the end. I'll see you guys next time. Thanks. Bye.